Good morning, everyone. My name is Samit Rathore, and I am working as a Deputy General Manager, Sales Department of Hetero Healthcare. On behalf of Hetero Healthcare, I would like to welcome you all this webinar on HIV care long-term survival. Before we proceed with the scientific agenda, I take this opportunity to brief on Hetero Healthcare, which has been a strong partners with HIV experts across the globe. We make more than 3 decades of our journey in HIV management. It started with the beginning of manufacturing and exporting of API and finished formulations of antiretroviral drug. Today, Hetero supplies 1/3 of the global requirement of antiretrovirals. Apart from HIV, Hetero has major involved in tackling the national emergencies such as swine flu in 2005 or as latest as COVID-19 epidemic. This was possible only due to the strong R&D team and state-of-art manufacturing facilities that ensures seamless supply of medicine. 5th June is HIV Long-Term Survivor Awareness Day, which means the long-term survival of epidemic and raises awareness of their needs, challenges, and journey. The goal is to prioritize on improving quality of life of HLTS and older adult aging with AIDS, as well as the overcoming another non-AIDS related physical and mental challenges. To discuss this further in detail, I would like to invite our speaker, Dr. Ishwar Gilada, consultant in HIV STD Unison Medicare and Research Center, Mumbai, President, Emirates AIDS Society of India, Governing Council member, International AIDS Society, Secretary General, People Health Organization, and Organized Medicines Academic Guild, involved with prevention, control, and management of HIV/AIDS since 1985. With this, I would like to hand over the sessions to Dr. Ishwar Gilada. Over to you, sir. I thank you everyone for joining us today.
Thank you very much, Amit and the team. In a succession, this is the second program for long-term survivors. First program we had last year. And when we talk about long-term survivor, then that means it itself says that people with HIV has no fear of dying. They're surviving long as any other HIV negative person can survive. In India, the average age of Indians is for male 71 and for female it is 73. And even if a person is diagnosed at the age of 20 to 25, we can take that person to 70 to cross that 71. It doesn't mean by 71 he or she will die, but they can even prolong beyond that. So that much normalization of HIV has happened, and in that the major share is also pharmaceutical companies, because that made it accessible and affordable for many people who are listening for the first time. The Indian pharma companies make medicine at 1% of the international cost with 100% same bioequivalence. And to give you a simple example, almost 20 or 22 years back, a huge delegation of international pharma company came. And when they were visiting my clinic, they wanted to take one of the or two of the bottles from us. And I said, okay, you pay the bottle and take. They took the bottle, and after till 1.5 years, 2 years, nothing happened. So at one of the international conference, I questioned them that you people came here, you took 2 bottles from me, of course you paid for it, but I have not seen those bottles in any international museum. So that means you must have analyzed in your lab and you kept quiet. And when you kept quiet, that means you did not find 1% impurity or less bioequivalence. And that is the state of affair of Indian pharma companies. Today, if millions of the people could have been saved from dying, I had been visiting Africa many times earlier, almost 50 times between 2000 to 2005. And there were people dying in such a way that they were doing a mass funeral of 8 or 10 dead bodies in the community. And on every Sunday, they used to do funeral because they could not afford the cost of funeral. So that was a scenario, and that scenario is totally changed, not because of innovator companies, it is because of Indian pharma companies. So with this, I would like to start my screen share and I'll go to my presentation. Are you able to see, please? Amit?
Yes, sir.
It's okay. So when we discuss long-term survivor, we are talking about those people who are, despite having a problem, which was described initially as a killer, deadly disease, and they're still surviving with that problem. Some of them are with treatment, some of them are without treatment, but they are surviving. So when we have to define long-term survivor, here I made a question to myself. Who are the long-term survivors? The first community is the doctors and the other healthcare personnel who have been caring for PLHIV. So I think any patient, whether it's HIV, non-HIV, any chronic disease, you need a doctor, you need a healthcare service provider. And we are also long-term survivors. So almost 20 years, 30 years, 35 years, 30 years, 38 years we have been practicing in this field. The second long-term survivor is the pharma companies making ARVs. If pharma companies make ARV and they would have vanished after a couple of years because it's not very big profit making company, or the product is not very much profit making, then we were in problem. So these two things are required for managing patient. You need medicine, you need a person who can decide which medicine is required for which patient. And third one is the people living with HIV/AIDS. Either they are on ART or they are on without ART. So those who have lived with HIV for many years are often called long-term survivors. Long-term survivors refers to those who have been living with HIV since before the era of highly active intellectual therapy, that is HART, in 1996. And there are also long-term non-progressor or long-term survivors, both elite and viremic controllers who are without ARV. So elite controllers are those who control their viral load despite having HIV to undetectable level, and not for a month or a couple of weeks, for years and years. One of my attendants in my clinic is long-term non-progressor. For almost 22 years, she has been working with me. And probably she has been infected 4 or 5 years before that. There are at least 50 to 60 patients in my clinic which are elite controller. There are another 30, 40 patients which are viremic controller. Viremics are those which have viral load around 1 to 2000, 3000, but they are beyond undetectable viral load. But that is not also progressing. So in these kind of patients, we do not start ART. We wait and watch. Every 6 months they come and they follow. So when a person with HIV come, then and now, there is not much of a difference in mindset of the person. It is still in the mind of the person that I'm going to die. So what do we do with my children? Should I have a child? Should I marry? If I have done engagement, should I continue? Should I have sex? There have been people who have just, despite all counseling, entered the bedroom and calling from midnight, doctor, should I do or I don't do? So that kind of a scenario. Should I use condom or not? Should I commit suicide? There have been people who came to Mumbai to see me almost 30 years, 32 years before. Decided to commit suicide at Grand Road station. That time my clinic was not at Grand Road. I used to practice from my home. And when they came, they said, the husband wife argued, and one of the person said that if you have come all the way from Hyderabad to see Dr. Gilada, we'll see him first and then we'll commit suicide tomorrow. It will not happen much if we postpone by a day. Until today, they have not done suicide. So that kind of question, job, homosexuality, heterosexuality, bisexuality, what do I do with my wife? Should I tell? There are still a number of patients who do not disclose their HIV status to their wife, despite having 20, 25 years of marital life. They are scared about death. They are scared about should I continue masturbation, which is safer, and relationship. So all these questions are to be answered. The best answer can be given by either by the peer counselors or by the doctors. So when we talk about HIV milestones in India, the first HIV cases were detected in Mumbai and Chennai, and the first case of AIDS was diagnosed in JJ Hospital. In 1989, HIV testing of blood units made mandatory in Mumbai after I filed a public interest litigation in Bombay High Court. At that time, it was not called PIL. It used to be called criminal writ petition. And on that petition, the High Court ordered an HIV testing started in Maharashtra. But that took almost 9 years time to get that HIV testing done in the entire country after the Supreme Court directive. 1991, the first case of HIV-2 was reported from Mumbai. 1992, NSCP was launched. That was 7 years after WHO started HIV awareness campaign. The Safe Motherhood campaign started during that time at Wadi Hospital with the WHO. 1998, we had HIV testing, as I told you, Supreme Court made it mandatory. 2001, PMDCT program launched by officially Government of India. It was 9 years after our initiative in 1992. 2004, we started, Government of India started free rollout. That was again 9 years after the private sector. 2010, we had free second line ART added to the program. 2019, test and treat provision for third line and viral load in public-private partnership. Now it is almost shifted to government setups and ART setups. Then in 2020, we started, Government of India started DTG-based regimen program and private sector started in 2017. 2024, now there is a discussion on quality of life and yet to take shape, but at least there is a discussion on quality of life. So when we talk about HIV, okay, the graph got declined, and it was not majorly because we have been able to control in a very big way. Because a lot of people with HIV were dying during that period, and therefore the numbers were going down. So when we talk about people living with HIV, it is not an absolute number of people who had HIV and who died and who are living. They are only those which are live, and that figure came down to almost 2.3 million in 2020, and thereafter for the first time they tried to jump it to 2.5. 2.5 is a magic figure. I don't know why we do not want to cross that figure on at least reality sense. But even if we consider 2.5 million infections, they are a huge number of patients. Though in absolute number we are huge, but when we consider population to patient ratio, we are almost at the 100 or 110 rank. In real numbers, we are at number 3. Number 1 is South Africa, number 2 is Nigeria, number 3 is India. And we have an incidence of 0.4% among the 1,000 population. We have a higher burden in the key population, so almost 70% of the new infections are happening in the key population, that too in young people between 20 to 35. And globally, 1.5 billion people get added almost every year, and almost 65% of that number of people dying with HIV. So despite having very good ART, people are still dying, and that is not acceptable. So in my talk, I'm going to cover changing trend in the age of the population, consideration before starting ART, even test and in the test and treat era, managing age-related age-related and non-HIV comorbidities, and there are a number of at each level I will tell you. Adult vaccination, holistic care and celebrations, and conclusion and take-home message. So this is a natural graph. This is called natural history of HIV disease. So if doctor and pharma companies and medicine are not interfered with, then what will happen to a person with HIV? And that was initially 5 to 10 years of life after somebody is diagnosed with HIV. And during initial course, viral load will go up, CD4 count will go down. Again, the person gets settled and stabilized. For 4, 5 years, 6 years, patient is stable, and then viral load start rising and CD4 start going down. And that is the point of intersection where a lot of opportunistic infections stepped in. The magic figure there was 200 CD4 count. So till 200 CD4 count, nothing much happens. Maybe some external symptoms, fungal infection, herpes zoster, tuberculosis can come in good and bad immunity. But once it goes below 200, then PCP pneumonia, tuberculosis, or typical microbial infection, cryptococcal meningitis, cryptosporal diarrhea, all this starts. And at the point of intersection, if you are not doing any test, as soon as the person is being followed up for years and years, and you start seeing the oral thrush in the mouth of the person, that CD4 count is below 200. So with this, then we look at all these symptoms as I told you, and then when we decide what is a treatment failure. So there are virological failure, immunological failure, and clinical failure. So if you want to wait for clinical failure, it will be too late. Immediately, what you can see is a virological failure. Then you see immunological failure. CD4 start going down. So sometimes if you are monitoring only CD4, you are not monitoring viral load, you will be making a mistake. Or if you think that I will come back when symptoms come, that may be too late sometime because viral load will go down, go up, CD4 will go down, and the person is internally being sick, but it is not manifest. And suddenly you start ART and the person can flare up because of iris. So we need to decide that. Then initially, suppose you don't start a good medicine, which can suppress you virologically and maintain that virological suppression, then viral load can go down, again start going up after some time. And that's what has happened in pre-1996 era, when initially we started with one drug, then we started with two drugs, then we started with the three drugs from the same class, nothing worked. They may have worked for 6 months, 1 year, 2 years, but beyond that, they did not work. The highly active antiretroviral therapy started with two different class of drug, and that time it was a protease inhibitor. Now the era is shifted to integrase inhibitor, and now almost 90% of the patients globally are on integrase inhibitor based therapy. So what can also happen that you have provided ART, viral load remains suppressed, and after some time the medicine stop acting, the resistance has developed, and then again it goes up. So it is not that you started ART, which is robust, like integrase inhibitor, and then you sit at home and just take medicine. At what point of time it will go up, we don't know. When you drive a car, you know at what point of time the fuel tank will be emptied. You can see that meter, but that kind of meter is not available in your body. Therefore, you need to follow up. We can debate on that. How long should be taken for to follow up? It can be initially 3 months, then 6 months, then a yearly. But yearly is must and which I will explain to you in my rest of the presentation. So if we have to decide, this is a slide of 2013. At that time, there was a in internationally there was a gap of almost 8 years between HIV negative person and HIV positive person. Today, the gap is non-existent. The gap has been totally breached. And sometimes we see, and I always tell my patient that my patients, every spare part is known to me, and I have been able to look after that part. But the patient's family member, brother, sister, husband, or wife, vice versa, who are HIV negative, not under any follow-up, I cannot guarantee them. During COVID, lot of those patients who were non-HIV under without follow-up, they died. My HIV patient did not die. I hardly out of 7,000 patients lost 3 or 4 patients, out of which 2 were being transported somewhere and they died. So that way, HIV positive person under good care and with good therapy, they live a better life, quality of life, quantity of life, less hospitalization. And that is why I will tell you why I equate HIV with any other diseases. So when we talk about comorbidities, internally there are so many organs, but most important we should look after is the CNS, cardiovascular system, renal function, and bone. And these are the important things when we either we are giving ARV or not giving ARV, we should look after them. And then there can be HIV related cancer, HIV unrelated cancer. So when we look at aging in HIV epidemic in India, we can see that the gap is now increasing. So we have more and more people with aging with HIV. Sometimes the people, there are two kind of group of people, those who are on HIV on treatment and they are aging. And there are those people who are aged and diagnosed for the first time. And we need to look after both, and we need to extend our horizon to look after them. So when we look at HIV in age more than 50, there can be no voluntary testing. What are the reasons? Because usually we suspect sexually active people more than the aged people. Our suspicion of a clinician also is limited. And then there are some kind of late presentation, late diagnosis, and there are some newly singles. You know, what happens is if you think that at 50 or 55, somebody lost a spouse and that person will stop sexual activity, we are in fool's paradise. And we thought of, again, I'll show you how there is a sexual activity boom, whether they are young or old or very old. So lack of awareness, low risk perception, and low condom use. Then there are non-HIV comorbidities, and which we need to also look at non-HIV comorbidities also, because if the person is aging, then the problem comes because of HIV, because of ART, because of his own age at that time, and because of some kind of hereditary factors happening in the family. So what are the risks with aging in HIV? The patient, everything is decided by a triangle. This is called disease triangle, host-parasite environment relationship. And in host-parasite environment relationship, the patient is most important, and that is because of individual gender. Usually we used to think that female is a weaker gender, but we found in all 30, 40 years, female is a stronger gender than male. genetics, hypogonadism, menopause, higher rate of traditional risk factors, smoking, dyslipidemia, hypertension, diabetes, obesity. Obesity can also lead to diabetes and hypertension, diet, physical inactivity, and poor engagement in care. Because what happens in a materialistic life, all small things which human being earn in a day's practice or 1 month of work, you have an annual maintenance contract. Whether it's a PC, whether it's an air conditioner, whether it's a car of belonging costing 5 lakh or 10 lakh. But your body costing a crores of rupees, there is no annual maintenance contract. And therefore, there is a poor engagement in care. Then there are issues with virus. It can be HIV infection itself. It can be inflammation and immune reactivation or reconstitution. It can be co-infection. It can be late diagnosis. It can be treatment related where ART and toxicity, drug-drug interaction. And drug-drug interaction, there are good sites to understand which are the drug you are taking for something else and whether ART will interact with that or not. And then diabetes mellitus, cardiovascular, non-AIDS emergencies and renal disease and osteoporosis, all these problems come. So as I told you, the disease triangle will be decided by these three factors. Now we are going one by one. I will discuss diabetes mellitus. So glucose and insulin metabolism, we need to have little focus. So relative risk of diabetes mellitus in an HIV infected person is almost double than non-HIV person. And one of the factor in that is also the component of ART. Prevalence of impaired glucose tolerance 18 to 35%, diabetes is around 9%. HbA1c underestimates glycemia in HIV infected person. So sometimes we just look at HbA1c, but that is not properly estimating. So when we need to do our diabetes screening and management, how fasting glucose is 126 and post meal is 200. So if that is the scenario, then we need to decide what is to be done with that diabetes. If 100 and 125, consider post meal and kind of glucose tolerant test. HbA1c can be around 6.5, though 5.6 is the normal range, but up to 6.5, there is no need of botheration. When fasting glucose every 6 to 12 months in all patients. So as I told you, the follow-up can be 6 months, but in a stable patient, it can be every 12 months. Consider testing 1 to 3 months after starting or modifying ART. Common culprits are lopinavir and some of the NRTIs. Now, how to manage individualization is the key. Goal for prevention of complication is HbA1c should be less than 7. And there are drugs which can interact in because a lot of people are integrase inhibitor-based regimen. In DTG, the metformin has a reaction. All other drugs of anti-diabetes, they don't have reaction. But there are good drugs like, say, raltegravir, abacavir, and FTC, TTC. They do not react with, or TAF or FTC, they do not react with any of the anti-diabetic product. And bictegravir is along with the DTG only that it can react to that extent. So if you compare dolutegravir with bictegravir, then dolutegravir is little bit more culprit because it is almost 40% more reaction with the metabolism of metformin. So then we need to look at the changing cardiovascular risk burden, increased longevity, increased prevalence of CVD. So if you are going to survive longer, you are going to adopt those diseases which are there for that particular age group. PLHIV has 1.5 to 2 times higher risk of getting cardiovascular diseases, 4.5-fold increased risk of sudden cardiac death. And now cardiac death is also blamed on COVID vaccine. But whatever could have happened with the COVID vaccine should have happened within 4 to 6 weeks of the vaccine and not after 2 to 3 years of the vaccine. So in CVD management, we need to look at what are the risk factors, age-wise, smoking, lipid content of your food, and there we need to put a block. We need to also look at waist circumference, 90 centimeter in men and 80% 80 cm in women. And we need to look at metabolic syndrome, how it can step in. So it can be low LDL, low HDL cholesterol, it can be high triglyceride, and always when you look at total cholesterol and triglyceride or TG, that should not be high. Insulin resistance and hypertension. Hypertension, initial culprit is obesity. But hypertension is a similar culprit to raise a problem related to cardiovascular system. So in managing, lifestyle modification is most important, and that is for all, irrespective of whether you have HIV or no HIV. In fact, those HIV positive people who have been going for regular follow-up, whatever advice has been given to them, irrespective of ART, barring ART, you should also educate your family members on other things, whether it's exercise, yoga, no smoking, no tobacco, and lifestyle modification, lifestyle modification, lifestyle and lifestyle I'll explain to you later. Pharmacological therapy is the lipid safe ART should be given by and large. Lipid lowering therapy, if required, if you cannot alter the ART, then we need to give a lipid lowering therapy as a daily routine. Management of metabolic syndrome and diabetes with metformin, and consider avoiding abacavir in patients who have elevated risk of cardiovascular disease. So, a safe to unsafe drug, if we go, the range is like this. And TDF is one of the best drug that way, but with the TAF and other things, they kept on getting added, and we have to replace to lipid safe part whenever it is required. Then going to bone metabolism, there's the bone mineral density or osteopenia, osteoporosis, and fractures, and a vascular necrosis of the femur. That means sometimes the person become paralytic, or sometimes because some fractures happen in the neck of femur, become bedridden. So in that sense, we need to look at what is the patient factor. The hypogonadism can lead it. Smoking and alcohol can lead to their vitamin D deficiency. During the COVID period, in almost 3.5 years, I don't know what has happened, but even beyond that, vitamin D deficiency is one of the major causes. And vitamin D deficiency also causes lethargy, body ache, bone ache, sexual problem, erectile dysfunction, and these are so cheap to even do that replacement. And I think in the program also at ART centers, they must look at vitamin D3 either testing or providing supplement every 6 months, at least 8 doses. Needs to be taken once a week only for 8 weeks. Then the treatment, which can be ART and toxicity and glucocorticoids, and it can be the virus, which can have HIV virus itself, inflammation, CD4, low CD4 and high viral loads, and co-infections, which can be HCV. And we need to look at all those issues. So if we look at a person living with HIV, the 6.5-fold increased risk of low bone marrow density and 3.7-fold increased risk of osteoporosis. So if this risk is high, that means supplementation of vitamin D3, a regular follow-up and regular checkup years after years is required. The prevalence in India in ART-naive patients is 67% osteopenia, 70%, and osteoporosis 29%. But ART experience, this same percent goes to around 80%. And in that, osteoporosis is almost 7% or 8% more than other people. So in management, we need, again, lifestyle modification, exercise, smoking cessation, alcohol reduction. We need to also look at pharmacological therapy like vitamin D, I told you. Safer for bone heart, which is the tenofovir to abacavir, PI to DTG. Then we have bisphosphates, alendronide or zoledronic acid, and other selective estrogen receptor inhibitor, parathyroid analog estrogen, etc. can be used. In renal, again, this is a big problem with some of the drugs and even by HIV itself. So it is called HIV-AN, HIV-associated nephropathy. So in that, BMI, smoking, hypertension, age, and diabetes, all these are contributing factors. And sometimes the patient will come, doctor, where is my kidney? And half of the kidneys are gone away by only one drug in the country, where people have been taking for the painkiller, popping that drug. And I can name that drug, but there's no need of everybody knows that drug which is causing problem. So that can be painkiller or NSAID being taken regularly for any pain. It can be TDF or it can be HIV related. So we need to look at what is the problem and provide a solution to the person. The TAF has a longer half-life in plasma, and TAF 25 milligram is equal to 300 milligram of TDF. So I think in the program also they should think of TAF because people are going to take ART for 20, 30, 35, 40 years. So replacing TDF with TAP preemptively also is a good solution in program. So what's so bad for two drugs? Sometimes a kind of a patient who is stable, virally suppressed, we can remove the third drug which can be culprit. In some cases like abacavir or TDF, when you have to remove, you have to decide whether it's a cardiac risk problem or bone and kidney problem. But in many people, after stability, you can put the person on two drugs. Actually, there are no good researchers to see that even one drug can work. But in HIV, the standard of care since beginning has been three drug therapy. Because when we failed with one drug or two drug, the three drug came in. So it is like a once bitten, twice shy. दूध से मुंह जला छाछ फूक के पीता है. And therefore, we are not going on a single drug. So at least two drugs are required, and that can be also considered. So we need to look at who is at low risk and who is at high risk of getting kidney problem, and that is decided by EGFR rate, the glomerular filtration rate. So around more than 90%, there is a low risk, but less than 70, less than 60, they're high risk. Age-wise, and also any other co-infections like hepatitis C, etc., or diabetes mellitus, they are at high risk. We also should look at the cancer screening, because as I told you, when you are aging, age-related problem can be caught up. So we need to look at all PL-HIV more than 30 years of age should be screened using oral visual examination. So a lot of time people coming to me from ART center, because sometimes when the patient cannot afford, we ask them to go to ART center for treatment. The patient comes back. We ask him, why did you come back? They said, sir, वहाँ कोई देखता ही नहीं है. वहाँ तो खाली आया बुक में एंट्री किया, मेडिसिन दे दिया. So at least look at oral cavity. So sometime by looking at it in another time occasion, I'll show you how I would diagnose oral papilloma infection on a tongue. So if you don't see oral cavity, which doesn't require more than 10 seconds, I think we'll be missing something. And at regular visits for tobacco chewer. And anytime you tell them, they are still, and we can find out whether they have got a submucosal fibrosis, at least annually for others. And we need to look at also cervical cancer screening, which is visual inspection with acetic acid. That's a pap smear. At ART initiation, repeat screening after 3 years. Women who have been treated should receive a follow-up screening after 1 year. Breast cancer screening, we should have clinical breast examination. You don't want to do that, there will be male-female problem issue. You explain self-examination to the patient, or tell the spouse of the person to see that. So all women living with HIV above the age of 30 at ART initiation, and then every 1 to 3 years, depending on how much we can do. We should also look at mental health. When we talk about mental health, then mental health of PL-HIV, they are at twice as likely to have a depression, because there are my first slide I showed you that there's so many issues going on in mind. And I always tell my patients, those who have some kind of hypochondriac behavior, that you keep your HIV virus in my drawer here, go from here fearlessly. You remember HIV only when you step in my cabin. And some people really do that, but most people cannot do that. So they have a stigma, rejection by the family, financial insecurity, dependence, fear of disease and death. There are at least 50 to 70% of the people who are groups of older adults with HIV show depression. And cause of non-adherence to all medication, including ARVs, and increase in suicide rate. So adherence is not only related to ART. There are people who have not been adherent to their daily routine. Whether they have been doing their daily toothpaste or not, we don't know. So there are people who will be non-adherent to a lot of their daily routine, hypertension medicine, diabetic medicine, and therefore they can be non-adherent to even ART. At least in ART, the concept of counseling is there, which was established like in tuberculosis, like in leprosy, but in other faculties, the concept of counseling is not there. And therefore, the adherence is better in ART and in those people who are with PL-HIV with ART, even for other things than other patients. We also should look at sexual health. There are a lot of times we come across patient told us the doctors told not to cohabit. Not to cohabit, I asked the patient, did you ask the doctor, can he stop cohabiting? So if the doctor cannot stop cohabiting, how can he or she expect patient to stop cohabiting? So I think we need to look at sexual health, and when we look at sexual health, we should be non-judgmental. It is not your personal life. It is not your family life. It is a patient. And patient can be homosexual, heterosexual, bisexual, LGBTQIA, anything. So your setup, health setup should be welcoming to any kind of patient. You cannot be judgmental with the patient. At the most, you can counsel the person, but beyond that, you cannot impose your ideology on the patient. And then you look at the apps which are openly available. So if you think that the apps are only for HIV negative people, you are wrong. There are HIV positive people who are using the app and who are engaging in sexual activity through hook. There are big hotels, five-star hotels where the homosexual community meet every Saturday, and there are 800, 900 people there with some 1,000 rupees cover. So you, and there are HIV positive and negative both. So I think we need to open up our vistas, understand that sexuality will happen. So it's better to advise them everything. It is up to them what to choose from that. Awesome. So we are talking about frailty, sexual health. I think my screen is not allowing me to talk on sexual health. We have to do another program. So when we talk about frailty, there are a lot of issues, and some ARTs can induce your premature aging. But fortunately, now the current ARVs which are available, they do not do that. Initially, there was AZT, there was D40. People are looking very old unnecessarily. So we need to also look at preventing opportunistic infection when the CD4 counts are particularly below 200. And now, one good thing the government of India has done, the TB control program has done together, is that the isoniazid prophylaxis is required only once in the beginning. Thereafter, you don't need it. Initially, it was every 2 years. Now that is changed. PCB prophylaxis only till 200 CD4 count. Toxoplasma prophylaxis when the CD4 count is below 100. Cryptococcal meningitis below 200. So likewise, we need to also look at other prevention. Now there was one patient who came to me just 4 or 5 days back, and that patient is on ART and had diarrhea. The patient is on ART for 15 years. Can you see how many drugs are given to stop diarrhea? And the patient is not stopping diarrhea. Patient was admitted, then colonoscopy, then a lot of other tests, and at least first seven medicines are for stopping diarrhea. One of the medicine is for psychological disorder. So patient is not psychologically disturbed at all, but disturbed because of diarrhea. So I think we need to, and the diarrhea got stopped with one antihistamine and 2 tablets of post corticosteroid or prednisolone. And I tapered that with 20 milligram, 15 milligram, 10 milligram, and 5 milligram. So I think there are some simple techniques required rather than going into gastroenterologist treatment for simple diarrhea. Then we need to look at adult vaccination. There are n number of adult vaccination. There are 14 of them, out of which we are selected, which are important. Hepatitis B is the most important thing. In next 8 or 10 years, hepatitis B will be bigger epidemic than HIV, tuberculosis, and malaria put together. And it can be prevented in pretense of the cost. Government of India has done one good thing, that from 2011, all children are vaccinated for hepatitis B along with polio, triple, measles, mumps, and that is a part of expanded program of immunization. Right from the birth, the first in couple of weeks, hepatitis B vaccine is given. But those who are born before 2011, particularly those who are not in the kind of good private care, then they need to take hepatitis B vaccine, and 3 doses will immunize you for whole life, and that is the cost is minimal. Then pneumococcal vaccine, though vaccine is expensive, but it is only 1 dose required for entire life. HPV vaccine is still expensive. 3 doses cost more than 10,000 rupees. Fortunately, one of the Indian companies started manufacturing. Government of India decided to introduce HPV vaccination for 9 to 14 age group of girls. But I have been telling that in 95 to 96% of the cases for female, they get any STD, including HIV or HPV, from male. So if you have a tubular vision of doing immunization of only girls, then you are solving 1/3 of the problem. You are not solving major problem. You need to immunize both boys and girls. Typhoid is again a cheap vaccine to be given once in 3 years. Influenza is little expensive, again once in a year. And varicella zoster is the most expensive vaccine, though one of the superstar is doing a big advertisement, but it is very expensive vaccine and we don't advise. And pediatric immunization program should continue as in HIV negative. It doesn't matter. In holistic care, we need to look at lot of issues, and that will help in normalization of epidemic. And what are those things? Stop addiction, and if not possible, please reduce. Healthy lifestyle, exercise, yoga, positive thinking, helping others, and it will come back to you. Tell people that you help others, people will automatically help you, because sometimes they are worried that if I fall sick, who will look after me? If I go to hospital, if they come to know what will happen? Adherence to medicine. Avoid polypharmacy, polypathy, and window shopping. Going to different doctors, taking different medicine, hiding, because the doctor will be wild if I tell him I went to that doctor. So you hide that aspect, then you hide that medicine, and then you do polypathy. Remember, HIV phobia is bigger problem than HIV. And Google is the biggest problem. So we have to tell people, don't Google. If you are in touch with the doctor, for me it's very easy. I tell them, if you are in touch with Dr. Gilada, you don't need Dr. Google. Beyond drugs, we need to also look at easy prescription, nutrition. Just diet once is enough. Sometime every 3-4 years we need to add. When we talk about millet, then we were looking at I didn't knew what is content of millet. Then when I checked and I found out that all these things we were eating since childhood. So a lot of things which are in our cultural practices, that should be part of your nutrition. When you tell how much to eat, the rice plate, there's a system of some hotels, rice plate or full khana. A rice plate is good enough for you. It has everything. It has chapati, it has rice, it has dal, it has sabji, it has one small, what you have, katori of curd, one small sweet, you have salad, you have papad. Yes, you don't need second serving. So you need to advise people involving family, caregiver, and support groups. So one of the support system should be available. If the person doesn't want to tell family, at least have some support group. Look at open-ended questions. Let people ask questions. Mental health, sexual health, avoiding multiple health visits, and comprehensive health care. So if you earlier we used to do that, my specialty is dermatology turned to HIV. Then I used to think that no, kidney problem I cannot manage. Send the person to kidney specialist. Send TB patient to respiratory disease person. And then the person end up going there, losing time, paying more money, getting a lot of tests done which are not required. So what is required now is a comprehensive health care. A doctor who is caring should almost 95% of the problem should be solved by the doctor. Only in rare circumstances the referral is required. The most important thing is stopping discrimination. An unfortunate part of the entire Indian system is that discrimination still continues in a very big way. Same thing we were doing 20, 30 years back, and we need to continue doing this again. In skin department in JJ Hospital, I'm talking about 1986, 87, 88 era. A lot of things I did in skin department. A woman was delivered in skin department. A baby was in skin department. So, but we didn't do longer. We just got those doctors, trained them, and then they started. So it became a center of excellence because it started almost 30 years before. So we need to look after patient without discrimination, without any kind of Dominic D'Souza. When Dominic was found HIV positive, he was jailed. We went all the way from here to Goa, fought. There's a film made on Dominic, but after 30 years, you go to Goa. There's the same discrimination going on. So I think our mindset has to change. We need to also work a little bit extra. Initially, between 1993 to 2008, I used to publish this AIDS Asia. And it was because I realized that only India can do that, and if it can go to some countries beyond India, information will go on. But after 2008, we stopped because nobody wants to pay. No, everybody gets free information. But at least those things which are required just one extra mile. We started HIV positive marriages 25, 30 years back. Now there are more couples who are getting married who are HIV positive and negative. And because of undetectable becoming untransmittable, that is convincing to a lot of people. And the other partner thinks that at least this person is honest and tells me that he is positive or she is positive. If there is a dishonesty and that person doesn't tell, or the person gets later on, then what will happen? Then we did a lot of programs where HIV positive person, caregivers, their family members, they're all on one platform. And the theme was ये जीवन है, इस जीवन का यही है रंग रूप, ये जीवन है. थोड़े खुशियां, थोड़े काटे, थोड़े गम है. So that kind of reality that we are all together beating against HIV. Now we started another celebration in our clinic. Any person who is following for 25 years. So at the turn of 25 years visit to our clinic, we order a cake and we cut the cake. And we hear that person's perspective of 25 years, what has happened. And during that period, we call our staff and we call whichever patients are waiting. We encourage that person to bring in their family, and it's a good celebration. So I think two things very important. One is a celebrating irrespective of you having HIV. And second thing is welcoming atmosphere. So if the person has vanished from care for 4, 5 years, 6 years, 10 years, and come back, don't scold. At least he has come back. So ask what were the reason? Why did not he come or she come? Rather than just holding that person. And when we look at how the changes happen, 25, 30 medicine at a time every day, that has come down to 2 medicine, 1 medicine. Then one medicine become smaller medicine. Now it becomes almost once in 2 month injection. Though injection has not yet come, but someday it will come. So I think there is a lot of change happened. And initially we were beggars. We are begging. Then we got so many tablets. Now we got single tablet. But you see, when we were begging and we got so many tablets, that so many tablets got changed to one tablet. Who did that? India. All these Westerners will have been telling that you people are copycats, you are Modi Xerox, you are this. Modi Xerox is not Prime Minister Modi. Modi Xerox is a company. So you make such a copy that people cannot make out which is original and Xerox. But when 3-in-1 came, we already had an experience of TB medicine, where 4-in-1 medicine was given. It is called 4-COX or something. So we told Indian pharma company that my patient takes 3 medicine at a time. Can you make 3-in-1? And one of the companies said, no, it is not accepted internationally, it is not done here. I said, internationally, there are different reasons because 3 different molecules belong to 3 different companies. Here you are making all 3 molecules. And what do we call? And I said, okay, call it Triomune. And that Triomune was named that time. Now, when this is copied from India, Westerners are copying. All over the world is a 3-in-1 medicine. But have you heard any time any Westerner, including WHO, UNAIDS, UN, given any credit to India that this is learned from India? So I think we should assert ourselves that it is India, which was from a beggar, now is a donor. And that therapy got changed from that to in 1990s to today. So what do people with HIV expect? And I think here a lot of questions might come, but what I thought was they expect low cost. If they're going free, fine. But if they're going in the private, they expect low cost. They expect single tablet regimen. They expect less adverse effects. They expect no food restriction. The earlier medicine used to be take with a hot food, take with oily food, avoid oily food. Now there are no restrictions. They need good survival. They need smaller size of or tablet should be palatable. One of my patients used to say, "अरे sir, ये इतना बड़ा गोली जाता ही नहीं गले में." So I used to say, "Okay, गोली खाओ और केला खाओ." वो केला push कर देगा. No physiological, pathological restrictions. No new disease condition, and build up and maintain good immunity. Everybody wants now good immunity after the advent of understanding of COVID. What do physicians expect? We want to also give a better survival to people so that the patient will come back again and patient will bring other patient. In any case, no physician would like to lose their patients. No emergencies from patient management. We did enough emergencies. We had to go midnight and attend patient. Now hardly any emergencies. So we also want that peaceful life. We don't want no adverse effects, and this adverse effect, if at all, no is not possible. Newer molecule and combos all the time. Because suppose same molecules are there, then it becomes a mechanical and technical. Anybody can give. Why you need a doctor? To remain consistent in approach and rapid turnaround time. So because sometimes you say CD4 is not important, then you say viral load is not important, then you say both are not important, then you say both are important. So we need to be consistent. And secondly, everything should be done in a quick time. And rapid turnaround time is the best thing because everybody is busy. Everybody has a time, everybody has to work. Ease in diagnosing and monitoring comorbidities when the person is on medication. Mechanism of age-related monitoring. So, what is the strength of private practitioner? I hear this. I'm not on debating on government versus private, but we have some strength, and because we are non-judgmental, we are non-discriminatory. We have a good rapport and good communication, and that helps ensure adherence. We have long-term commitment. We are not fly-by-night operators. Yes, there are some doctors who may have started some different practice like cosmetology or emergency medicine, but by and large, many people which have started HIV practice 30 years back, they are consistent. Caring pediatric to geriatric. So we don't expect child to go to pediatrician. We don't expect old person to go to geriatric. We are providing everything to our patient. Knowledge, specialized, abreast with current developments, open to quick adaptations. So even after my talk, some doctor may adopt. So we are quick. We don't need any government circular to tell us what is to be done in a betterment of the patient. So adverse effects and co-infection management. We also do welfare of patient, rapid turnaround time, a point of care, everything is at the one setup. New and bold initiative where innovation translates into practice. 3-in-1, as I told you, is initiation of the private practitioners. ARV dose reduction, that 600 to 400 milligram. We started actually half the tablet, 300 milligram. Now 400 milligram, a lot of people are happy. All different combos available, so quick correction or switch possible. So we don't need a circular again to do that. So basically, we must look at one thing, that there are 4 C's, and it cannot be one size fit all. Cap, you need a different size. You need clothes, you need different size. Chappals, you need different size. Condoms, you need different size. Similarly, we need to individualize ART. And we also look at other parts of prevention aspect which are not even looked in other setups. So we also sometimes, though male circumcision is not very common and very acceptable in India, but there are people with phimosis who are always more exposed to infection and getting male circumcision. The oral prep, PEP, male condom, female condom has never become popular, and diagnosing and treating STI, it has now again come up in a very big way and very popular. Now, looking at HIV/AIDS Act, a lot of people think that HIV/AIDS Act has come. No, it has not come suddenly. We started from Goa. Thereafter, if you look at this letter from Government of India, it is, I think, 1989. From that time, we have been fighting for getting this law. Law has come. And the game changer has been this HIV/AIDS Act. It has been test and treat, and it has been viral load testing. But despite having the law remains toothless. More than half of the states do not have ombudsman. I hardly see any single case where somebody is prosecuted because of this act. I always get patients who are denied insurance despite getting a clear indication from the insurance agency, IRDAI. Despite that, the insurance companies are denying. So I think here PLHIV community need to fight, need to assert their right. Whenever any doctor or any hospital or healthcare setting is discriminating, fight over that. And even if you don't have to do anything, you can always threat them that this act shows, and it provides 6 month to 2 year punishment if you discriminate. So despite all these things, what we have done in 35, 37, 38 years, there are still major challenges. Most doctors are not interested in HIV now, and they want to keep away from HIV patient. Unfortunate. Test, you go to surgery, you go to gynecologist, out of 10, maybe 9 are not interested. Test and treat has its own challenges. Lack of trained and committed workforce at ARP center. The frequent stockouts are also there of one or the other medicine. Management of OIs and co-infection, metabolic disorders and advanced HIV disease that is still being in a rudimentary stage. Lack of policies and guidelines, and particularly for aging population. Vanishing pediatric ARVs, and now we call them orphan drugs. MDR and XDR TB, MDR and XDR HIV, and resistance testing is not available at affordable cost. Iris sometimes with more fatal condition. Lipoatrophy, lipodystrophy, PLHIV marriages and alliance, young and old, positive, negative. Still, a lot of people are single. We need to do something for them very actively. changing pattern of sexuality and STIs, and discrimination of people with HIV despite this act. So you can see lipotrophy, lipodystrophy. There are hardly any surgeons who would like to help such people. Then it was a prevention is the only treatment. Now treatment as prevention. So there's a total shifting focus. And what is important? Undetectable is untransmittable. And I added one more line. Undetectable is untransmittable, and it is also equal to life fully predictable. You can predict the life as good as HIV negative or even better than HIV negative. And with the same ideology, we started in 1995, the Unison Medical Research Center. It is now in 30th year of formation, and it has everything under one roof. There is a counseling, there is a testing, there are different lab tests, all the PCRs are done, gonococci, chlamydia, HPV, HPV. Probably we are the only clinic in the country which does HPV PCR from male sex with male from anoscopy. So I think all these things are provided at affordable cost under one roof, and that is a so what happens? How the wish list got modified in 1980s, mere death sentence it was, and death made headlines, and it was blame game, and it was always blaming somebody or the other. Even I had to quit my service from JJ Hospital because all this blame game. The moment I diagnosed cases, they used to think this doctor doesn't know anything. There was no AIDS like that. So often we used to do टर्मिनेटर काउंसलिंग भी आप मरने वाले मरने की तैयारी करो क्या क्या करना है माँ बाप को इसको भेजना है बद्रीनाथ को जल्दी भेजो बच्चों के लिए सेविंग करना जल्दी करो बीबी के साथ झगड़ा होता है मत करो सो दैट काइंड ऑफ टर्मिनेटर काउंसलिंग यूज्ड टू डू 1990s गिव अस फ्यू डेज योर पेशेंट विल कम सर मेरा बच्चे का एंगेजमेंट शादी तक का मेरे को टाइम निकाल एंड लेट मी पुट माय हाउस इन ऑर्डर अटेंड सम पर्टिकुलर इवेंट एंड वी स्टार्टेड टेलिंग ओके 5 साल का प्लान बनाओ अभी आजकल में नहीं जा रहे 5 साल का प्लान like a government program of national 5-year plan, you make your own 5-year plan. In 2000s, ART prolonged lives, prevented deaths, prevented infections, and then hope got more wheels. People got hopeful. 2010s, marriages, restarting sex, having child. A lot of people who have a 15, 20-year-old child, sir, can I have a second child? Let's be have it, have it. Child's marriages, and normalization of pandemic and confidence growth. 20 now in this 3-4 years, quality of life has become important. Can I see my grandchild's wedding? No, first self-wedding, then child's wedding. Now they want to see grandchild's wedding. And HIV is better than diabetes. I've been telling that if God Almighty comes to you, those who are HIV negative, and tells you must take one disease. In one hand there is HIV, in the other hand there is diabetes. I think smilingly you take HIV, don't take diabetes. Because in HIV there are no restrictions on food, on a lot of things. In diabetes there are a lot of restrictions. In diabetes you die of a heart attack, you don't get even chest pain. So in all the sense, and cost of management of HIV cheaper than cost of managing diabetes. What we can ensure or assure HIV positive person once virally suppressed, full life, to life expectancy at birth. So whatever country you are born in, if your life expectancy of birth is around 71, 73, 80, you live that much life despite having HIV. No HIV related hospitalization, no HIV transmission to your spouse or to child. And you can marry both HIV positive, 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 negative. But when you are marrying a negative, just disclose. Don't keep the person in dark and marry. Can have baby and that too HIV uninfected. So as I told you, we have gone in a big way. Now injectable, I think that slide came double. And helping age with grace. Basically, that is the only thing it has come to you. If those who are aging, just enjoy your aging. Look beyond what you see. Widen our management focus. While lifestyle changes remain the most important pillar, continue statin, bisphosphonates when needed. Strengthen the screening strategies. One-stop shop as far as possible. Avoid polypharmacy, polypathy, and hybridopathy because sometimes we do not know what is the effect of Ayurveda or homeopathy on this particular medicine. Optimize heart. One size fit all doesn't work everywhere. Adult vaccination, HPV and HBV are important and crucial, and they are also like a prep. And listen, normalize situation, focus on quality of life. Thank you very much. I don't know how I went because I didn't see the watch. I told Amit and Harisha earlier that I might go a little bit overboard because I enjoy talking to my colleagues and my patients. And I think I have been of some help to you. Thank you.
Yes, sir. Thank you, doctor, for insight, detailed explanation on the current scenario of managing HIV and prevention from HIV. Sir, we have received few questions. If you could allow, then we can proceed with the question.
Yeah, yeah.
Yes, sir. So, sir, the first question is from Dr. J.C. Das from Delhi. Um, what about the latest updates of PrEPs and PEP? Please explain in your own experience. Is it sure and safe or depending upon viral load?
No, PrEP is very important thing. I think we need all the tools, whatever tools are available. Now, I have been debating with Government of India. We at one of our conferences, I asked them that you are providing free ART lifelong, but you are not willing to provide PrEP. That means you are asking people, you get infected, we'll look after for whole life, but I will not give you a tablet for preventing infection. So if you have been able to give condom free, this is another, condom is also a non-pharmaceutical PrEP. So why you are not giving PrEP? And the officer laughed, and till today it has not come. We were expecting that the PrEP will be announced during our national conference, which happened 2 months before. But PrEP as official policy is not announced. PrEP doesn't cost much. And PrEP is required on daily basis for those people who have been having multiple partners and multiple sexual interactions, irrespective of viral load or not. But those who are having a steady partnership with the undetectable viral load, they don't need a PrEP. So even a spouse, if husband is positive, wife is not, or vice versa, and the person is on a good therapy and consistently two viral loads are undetectable, the other partner doesn't need PrEP. Even for getting pregnancy, even during pregnancy, they don't need a PrEP. Secondly, those who are going to have once in a blue moon experience, because some people plan and go to Thailand, so and they go for with the planning of having sex there. So in that, it's called event-based PrEP. In event-based PrEP, it is 2 tablets 12 hours before, 1 tablet at the time of event, and 1 tablet 2 hours after, 12 hours after. That means 4 tablets per incidence. But suppose somebody is going to Thailand and going to have 3 days daily sex, then 2 hour, 2 tablets 12 hours before, and one each day is at the each event, and then again last will be after 12 hours. But if you are not taken PrEP, you need PEP. And basic PEP and PrEP, they are the same medicine. Only advanced PEP, you require a third dose, a third molecule. So I think PrEP should be part of the program. PrEP should be available everywhere. And people who are having multiple partners and multiple risk factors, they should always take PrEP daily. Unfortunately, even with good counseling, those people who started PrEP, hardly 4 to 5%, maybe not more than 10%, they consistently take PrEP. They've not done one single gap. And we have seen patients who taken inconsistent PrEP and coming back with HIV infection. Dr. Das, I hope answered your question.
Thank you, sir. So the next question is from Dr. Rajesh Gopal. That is, long-term non-progressives need to be analyzed very systematically to carry out appropriate research to devise cure or vaccine for HIV.
No, of course, they need to be analyzed. I always say that you need an individualized care. You need to individualize strategy. So, and as per their age, you need to decide vaccination. As per their affordability, do you need to decide about vaccination?
All right.
And I'm including Hitro, I'm expecting our pharma companies and our vaccine companies, particular vaccine companies. Now you don't have much of COVID business. Come into this kind of business. You need HPV vaccine. Hepatitis B vaccine is cheap available everywhere. HPV is very expensive. And all these multinational companies coming in my cabin, I said, every time you are coming, you are increasing the cost. The HPV vaccine has gone up from 1900 to almost 4,000. And then now they are giving nanovalent for 11,000. So I think they said, no, sir, you give it to affordable people. I even don't want to give to affordable people. I don't want to encourage them at all. So I want to encourage you people to bring in indigenous vaccine, and we are good enough to bring it. My calculation is very easy. A pharma product is 1 to 3% of international cost. Vaccine is 10% of international cost. So even 4,000 rupees vaccine, it will become 400 in India. Then people get used to taking that, and we can advise as quickly as widely as possible.
Thank you. Uh, the question is from Dr. Bobby Rama. Are there any long-term HIV care guidelines in India and other
I'm not able to, I'm not able to hear.
Sir, there's another question from Dr. Bobby Ramakant.
Yeah.
Are HIV care outcome guidelines in India and other countries to monitor viral load, viral suppression, loss to clinic, and other indices?
I think our viral load monitoring has been good. Uh, the only unfortunate thing is that it is in some centers they are doing every year, in some centers they are not doing every year. And secondly, it is not the results are not given early. So when somebody goes for checkup this year, this month, the report may be given when the person goes for the next field after 3 months. During 3 months, if there is a virological failure, the person will be continuing the failed in medicine. And after the medicine is failed in, they will do counseling. They will again ask them to come after 3 months. So sometimes the patient is on a failing regimen for 6 months. And then the SACEP will decide which medicine should be given because the person has failed. In that situation, it takes longer time. So I think there we must look at, but otherwise your transition from no viral load to public-private partnership viral load, public-private partnership viral load to now in program there's available almost at all places, and that viral load is being done almost for every patient, at least once in a year, but in some places they don't do.
All right, sir. So the next question is from Dr. Rapulu Satyanarayana. What is the status of vaccine for HIV?
That is a big failure. There have been some 99 to 100 candidate vaccine, out of which only two went to the phase 3 trial, and both of them failed. The problem with HIV and the solution from HIV, the mRNA platform of HIV vaccine preparation was used by two different companies for making mRNA vaccine, and third company from Pune. So they made COVID mRNA vaccine, but they were not successful in making HIV vaccine. HIV is, though we think that COVID has a lot of variants and subvariants, HIV is more what you call having this kind of types and subtypes than them, and it is quick changing. So you cannot make a polyvalent vaccine which will work for all current variants and subvariants going to come in future. That is one issue. Secondly, now the vaccine research has taken a backseat because people are surviving on ART. The major research will happen only in HIV cure rather than vaccine. And secondly, they will not get people who would be willing to take vaccine if we're talking about the therapeutic vaccine. For preventive vaccine, those two vaccines, Vaxgen and one more vaccine, both failed, and they were around, one was 49% success, one was 30% success. So if it doesn't cross 50%, it is not going to be commercially available. And more when the people taking ART, those who are on HIV and ART, by taking ART, they become undetectable. By becoming undetectable, they will not transmit. So therefore, the purpose for research for vaccine is not in a big way.
Okay, sir. Thank you. So the next question from one more doctor is that as U is equal to U or long-term HIV care outcomes are so critically important, how can we ensure programmatically that long-term HIV care monitoring is not ignored anymore?
I think in program, if they have every quarter one visit for a patient who goes only for refill, at least once in a year you have a good physical checkup. And I'm saying good physical checkup, it doesn't mean that you need to spend half an hour, 1 hour. You spend at least 10 minutes on the patient, do a proper examination, check their blood pressure, check their weight, check their mouth, check their other systems, and also include some of the testing which are required as per age. So those testings are not done in the ART centers. They are equipped with only 2, 3, 4 different tests. So they are not doing in most of the places, even lipid profile is not. D3, B12, they are very far. They are not even advised anytime. Neither the treatment is advised, nor the testing is advised. So I think we need to expand horizon. We offered our services from AIDS Society of India to Government of India. We written them lot of letters that you let us know where you need us. We are not even asking you fee. We can travel at our cost. We can do programs at our cost. You let us know. But there is, see, at one point of time, you can only ask. If they are not forthcoming, we cannot do anything. So when we are talking about a big problem, we need to all beat it together. Whether it's the community, whether it's the government, whether it's the society, whether organization like us or doctors. And fortunately, in the field of HIV, we don't have many greedy doctors. So we are not even asking. We are doing well in our practice. We don't need anything from government to give us for doing that kind of advice. Let us. We told them you can use us for recruitment of ART officers. You can use us for training ART officers. You can use us when you want to have a kind of a setup to be done. What testing is required. Some of us are already on the government's committee on TRGs, advising them, and we are attending and advising them time and again on treatment guidelines were there. But I think they should also have little bit walking on extra mile like we have been walking. If that is not done, the long-term care will be always a question. And fortunately, our community is docile. They are not like in many other countries. You see, you go to international conferences, all the stalls are disrupted, all these things are disrupted by PLHIV. India, nothing that sort of happened. So when the community is cooperative, when doctors are cooperative, when we are not expecting any big thing from them, do it. And we need to do it because people are going to grow. And secondly, if you cannot afford, don't do 100% free treatment. You use a Tata hospital model, three-tier type of pricing. You give lowest cadre totally free treatment, middle cadre at cost, higher cadre you charge more. Why you expect a person to come in Mercedes Benz and take a free ART from government setup? So I think we need to debate. We need to change our policy. We need to change our outlook. Then only we can look after long-term survivors. Otherwise, we are just doing a piecemeal approach of one thing and we are making the person to suffer. Unfortunately, almost by the government own data, 19% patients on DTG-based regimen are hyperglycemic, diabetic. So I think it's a big, huge, you're creating, you're solving one problem, creating another big problem.
Yes, sir. Rightly said. So we have few questions from general public and patients as well. These are some basic questions as well, sir.
Yeah.
I am positive and how we save from being HIV positive.
From?
I am HIV positive and how
Ah.
we can save from HIV.
How we can save from HIV?
Hmm.
No, you are HIV positive, take regular treatment, good treatment, keep your viral load suppressed. You don't need to do anything extra. That's why I've been telling कि आपको HIV है, आप डरो मत, कोई बात नहीं. There's a couplet which was used by a patient when I was working in leprosy in 1982-83. When the patient was not cared by a doctor, doctor didn't touch, and he said, किस्मत की बदनसीबी है सयाद क्या करेगा, हकीम है बेदर्द तो फिरियाद क्या करेगा. Said because of my bad fate I got this leprosy, but if doctor has no compassion, where can I go? And I realized that my junior resident that time did not touch the patient, talk from a distance, Baba aap kaise ho? And that person thought I am untouchable. So HIV positive person need same kind of care as HIV negative person needs. Just put a pat on the back, just give a hug, shake hand, let them feel that they are not untouchable. Unfortunate part is the contagion is in the mind. And for 30 years, I've been saying more the educated, more the discrimination. Less educated, less discrimination. Highly qualified doctor, more discriminatory. Highly qualified person, more discriminatory. And illiterate people, they are, अरे मेरा भाई को कुछ हो गया आप सब बचाओ. Other people will come educated after the patient goes out. मुझे तो कोई डर नहीं है ना, मेरे बच्चों को तो कोई डर नहीं है ना. So I think that mindset of contagion has to change. तो HIV पॉजिटिव आपको कोई बात नहीं, कुछ आपको एक्स्ट्रा करने का जरूरत नहीं. आपको खुद होके किसको बताने का जरूरत नहीं मुझे HIV है. Why you want that sympathy? You don't need sympathy. You don't. Empathy or sympathy is on the other way. Whether they want to give or not is up to them. You don't seek. The moment you seek, you discriminate yourself. I think more than 50-60% discrimination starts because of your own behavior. आप खुद जाके बताते हैं मुझे HIV हो गया, क्यों बोलना है आपको? सब पेशेंट कमेंट से मेरा दांत निकल जाऊंगा या डॉक्टर को जाऊंगा, बोलना है नहीं बोलना है. वो क्या प्रिकॉशन लेना डॉक्टर का काम है. There were issues where the doctor said, "Doctor, you are unethical." I said, "If you are unethical, you are expecting me to be ethical. If I refer to you as a HIV positive person, you didn't do surgery, you didn't do the delivery, and then when I said my patient almost is 70-80% are HIV only. So when you knew my patient, you should have taken precaution. What extra precautions you need for HIV? You don't need anything." HIV, for 30-40 years, I have not been using gloves in examining patient or mask when I'm sitting with the patient. I didn't get HIV. No, there are people who will say, "अरे आप तो कभी सर्जरी किए नहीं ना, आपको क्या मालूम?" There was one surgeon who used to say, "वो हमारे पास इक्विपमेंट नहीं, क्या नहीं है, हेलमेट नहीं है." अरे बोले यार, कारगिल का वो वार हुआ, उसने हेलमेट नहीं मांगा, आप हीरो हेलमेट मांग रहे हो. So there are people like that, but HIV आपको है, कोई डरने की बात नहीं. आपको कुछ एक्स्ट्रा प्रिकॉशन लेने की जरूरत नहीं. आप दवा खाओ, बट दैट इज ओनली प्रिकॉशन यू शुड टेक.
Yes, sir. So, in line with the same question, what can help while dealing with misunderstanding or judgment from family and friends if a person is HIV positive?
So to get firstly when is a train derailment, there is a more divergence. तो अगर मिसअंडरस्टैंडिंग बढ़ता गया पहले से तो काफी लेट हो चुका है. लेकिन नेवर इज बेटर लेट देन व्हाट यू कैन बेटर लेट देन नेवर. ब्रिंग योर फैमिली मेंबर इन केयर. जब आपको लगा कि आपके घर में कोई डिस्क्रिमिनेट कर रहा है, तो नेक्स्ट टाइम उसको लेकर जाओ, डॉक्टर को पहले से एडवाइस करो कि सर मेरे साथ मेरी माँ आने वाली है या मेरा बहन आने वाली है, मेरा भाई आने, आप उसको समझाओ. तो वंस वी गेट आइडिया कि वी नीड टू व्हाट वी नीड टू टॉक, देन वी कैन काउंसिल. But once you go to the setup and then they get the complete idea what is undetectable is untransmittable. So I always tell undetectable untransmittable to his wife who is having and cohabiting every night. If she is not at risk, how come you are at risk? Or how come child is at risk from eating from the same plate? So we need to tell them. We have in last 6 years or so 176 children born to HIV positive mothers. Not a single is positive. So when they come, we give this example and that convinces them. So I think discrimination first realization discrimination started, stop there and there. I'll give you a very good example. One of my patients survived for almost 28-29 years. And as soon as he was found positive, he was discriminated by his father and brother's family. Totally isolated. Husband, wife both positive. Wife is on no treatment. She is a elite controller. Till today, 30 years, no treatment. Husband is on treatment. And he wanted to educate his son and make him pilot. Unfortunately, today that person is a pilot in one of the airlines. And till that time, he didn't tell his son. He brought the son and son-in-law and daughter-in-law to me. आप बताओ. And when I told, the son started fighting with father. आपने मेरे को अभी तक क्यों नहीं बताया? And father cried and said that अगर डॉक्टर साहब इसको पूछो, अगर मैं इसको बता देता था कि मुझे HIV है, ये अमेरिका जाता था क्या? तो ask him. बोले नहीं, मैं नहीं जाता. बोला इसलिए फादर ने नहीं बताया. And that day his father's birthday was there. Means my patient's father. I said call your father. नहीं मैं नहीं बताऊंगा. मेरे फादर ने मेरे को ऐसा किया. अरे मतलब बताओ यार, तुम बच्चा है. And he called his father from my clinic and he put on speaker and I told his father that the day you discriminated him, that was wrong, but he is calling you, let him come.
Yes.
His son has become now pilot. So the discrimination stopped there. The occasions where mother-in-law discriminated against her daughter-in-law. इसे मेरे हाथ से वो मेरे कपड़ा अलग रखते, मेरा चाय अलग रखते, मेरा ये अलग रखते, मतलब मैं आज घर में आ रहा हूँ. Today I don't have time to go to every patient's home, but during those days I used to go. मैं आता हूँ, आप चाय बना के मेरे लिए लेके. तो वो सास बोलती है, अरे सर उसको HIV, मतलब मुझे मालूम है HIV, उसने लाना था चाय, कुछ फर्क नहीं पड़ता.
Hmm.
The discrimination stopped there. So we need to be examples. We need to ask person to bring. Now there's a advent of video call video. Tell patient कुछ नहीं होता है. और अगर इसके बावजूद भी करते हैं तो then there's other reason of discrimination. HIV is not the reason. Because mother-in-law will discriminate daughter-in-law for any reason. So HIV is one of the reason. So you try your level best to remove the HIV component of discrimination. If that helps, fine.
Yes, sir. So the next question is, how does regular exercise, yoga and physical activity help?
अभी क्या बताऊं, मैं तो करता हूँ, मैं तो फिट हूँ. No one can make out looking at me. I'm 66 plus. My age, my weight doesn't increase 1 or 2 kg. Anytime you come and see me, I don't do die because people say die क्यों नहीं करते हो? I say I will die only once. Why should I die every Sunday? So exercise, yoga, इसका फायदा है. And your redistribution of fat happens. Your bone becomes unstiff if you're stiff. Your lifestyle is sedative. Currently, work from home is a big disease, or people are not understanding. It's going to be a very, very big pandemic. घर में बैठने का, चाय उधर ही है, नाश्ता उधर ही है, खाना उधर ही है, टॉयलेट बाजू में है, और बैठे बैठे चाय लेके आओ, पानी लेके आओ. What kind of disease, what kind of life you are leading? Talking to only a screen. You don't see people. So I think everything, exercise, yoga, going out, meeting people, having friends, families, that all helps. If you want to compare, then we need to do a good research of control population in this population, but it helps.
Yes, sir. So the next question is from doctor. Do you see any cases of AIDS survivor syndrome and how were they managed?
AIDS survival syndrome.
Huh.
What is survivor syndrome?
So that's the question is, do you experience any kind of AIDS survivor cases and how were in your clinic and how were they managed?
No. If he is asking how long they are surviving, I have patient of 1991, they're still alive. And as I told you, the last slide which I showed you how the wish list changed. I'm not talking on my own. I just out of experience. पेशेंट की शादी होना कि नहीं होना, शादी हो क्या है, साथ में रह कि नहीं रहे, बच्चा करे कि नहीं करे, बच्चा हो गया, अब बच्चे की शादी करना है, डॉक्टर साहब आप आओ. So all this they are surviving. And long-term survival can be without ART also if they are viremic or elite control or viremic controllers. So they are doing well, very well. And sometimes patient's spouse who is negative died. Patient's brother younger than him died. Some relative who are HIV negative, they died. Patient is survived. So we started earlier when we used to say, अरे डॉक्टर साहब आपको आपकी दुकान चलाना है इसलिए बोल रहे इसको चेकअप करने. But I tell you, मेरे पास मत करो, कहीं तो जाके चेकअप करो. You once in a year, once in 2 years, my patient doing very well. You are not doing very well. So एक अपना एक एक्स्ट्रा शब्द बोलने से क्या होता है? कोई रिलेटिव आया, अरे भाई आपका वेट बहुत बढ़ गया, कुछ करो, इतना ही बोलता हूँ. जहाँ ट्रीटमेंट करना जाके करे. तो लॉन्ग टर्म सर्वाइवर के वजह से दूसरे उनके रिश्तेदार है, उनको कुछ सीख लेना चाहिए. भाई ये डिस्पाइट HIV से लॉन्ग टर्म सर्वाइवर का 2 प्रॉब्लम है ना. आजकल के जो हमारे बच्चे डॉक्टर प्रैक्टिस कर रहे हैं, उनको तो बस अब सिल्वर प्लेटर पे मिला है. एक थेरेपी मिल गई, एक गोली दे दो, बच्चा जी रहा है, कोई भी जी रहा है और उसको क्रेडिट मिल रहा है. हमारे समय में मेडिसिन नॉट अवेलेबल, नॉट अफोर्डेबल. हम लोग क्या जगलरी करते थे, हम लोग उस पर 2-4 घंटा बात कर सकते हैं, यानी पेशेंट को कैसा जिंदा रखने के लिए हम लोग करते थे. और उसी ढंग से वो पेशेंट को भी बेचारों को यानी आई टेल यू वन एग्जांपल of one medicine which was called Crixivon, Indivir. Indivir was available in black market in Mumbai. There were only 2 shops where they could get from anywhere in the world. तो 14,000 का, 15,000 का, 20,000 का वो एक मेडिसिन आता. और साथ में लैम्यूडिन और एजेक्टी या लैम्यूडिन और कुछ मेडिसिन उसका मिला के 17,000 कॉस्ट होता था. आई एम टॉकिंग अबाउट 25 years बिफोर. 17,000 का कॉस्ट आज उसका 2 लाख, 2.5 लाख, 3 लाख वैल्यू होता है. उस समय लोगों ने कैसा लिया होगा, और बेचारे छुपा के घर में किसको बोलना नहीं है, दवा लेने का है, वो टाइम निकाला. अभी वो पेशेंट अगर जब व्हाट वी लर्न फ्रॉम देम is during that cake cutting celebration. वो पेशेंट आके बताता है हमने कैसा कैसा टाइम निकाला है. There used to be only one company, Cipla, making that medicine, and medicine was not available to doctors or patient so easily. So we used to keep one assistant doctor to go to the Cipla, go down and get medicine with the patient. Patient बोलता था मुझे नाम नहीं देना है, वो डॉक्टर वहां खड़ा रहेगा, उसको 1 महीने का दवा मिलेगा. We gone from that time. We imported one medicine, Combivir, Lamivudine AZT from Singapore for 10 patients. बोलता था advance. Glaxo used to tell us, give us advance medicine, 3 month cost. We'll import from there, get a license from permission from Director of Health Services or this authority. By the time medicine come, 2-3 patients would have died. ऐसे हालात से निकले. तो अभी तो बहुत आसान है. तो लॉन्ग टर्म सर्वाइवर की स्टोरी सुन सुन के जो नए सर्वाइवर है उनके लिए काफी इंस्पिरेशन मिलता है, पक्का है. Whenever they come to our clinic, when they talk to other patients, they inspire them.
Yes, sir. True. So the next question is, what are the long-term toxicities of the medication?
ये बड़ा चार्ट है, लेकिन इवोल्यूशन ऑफ मेडिसिन में जैसे मेडिसिन के नंबर कम हो गए, 15-20 से लेके 1 पे आ गया, और उसके अंदर के कंटेंट हो गए, साइज कम हो गई, उसी ढंग से उसके साइड इफेक्ट भी बहुत कम. तो बाय एंड लार्ज मेडिसिन 20 साइड इफेक्ट वाले. जो प्रॉब्लम हो सकता है वो DTG से, बिक्टेग्राविर से, शुगर का हो सकता है. वो आप अगर 3-4 बार देख लो और एक बार सेटल हो गया, ठीक है. वो अगर उस पर 1-2 साल में पता चला, देन यू हैव टू शिफ्ट टू अदर मेडिसिन. पहले एटाजोनाविर को बहुत नाम रखते थे कि आंखें पीली हो जाती है, और वो आंखें पीली होने का रीजन था कि पेशेंट पानी कम पीता है. हम बोलते थे पानी पियो, आंख का पीलापन निकल जाएगा. किसी ने पूछा आंख पीली क्यों है, रात में नींद नहीं आई बोल के. कुछ नहीं प्रॉब्लम, हार्डली एनीथिंग. तो लॉट ऑफ थिंग्स. अबाकाविर का बड़े इतना साइड इफेक्ट है, हमारे यहाँ इतना देखने को मिला ही नहीं. अबाकाविर से एलर्जी होती है स्किन की, हार्डली किसी देखने को मिली. तो ये बहुत सारी चीजें अलग अलग पॉपुलेशन में कहीं हुआ होगा, लेकिन हमारे इंडियन पॉपुलेशन रगड़ है, सब हजम कर लेते, कुछ नहीं होता है. तो ज्यादा कोई साइड इफेक्ट नहीं है. आप वो साइड इफेक्ट के डर में मत जाओ. साइड इफेक्ट देखने का काम दूसरे का है, लेकिन आप पॉलीपैथी करते हो, क्या क्या अंदर होता मिक्स, वो हमको पता नहीं. तो पॉलीपैथी मत करो. एक कंसिस्टेंटली मेडिसिन लो. हम किसी मेडिसिन के खिलाफ नहीं है, लेकिन आप 2-3 मेडिसिन साथ में लेते तो ऐसा कोई रिसर्च हुआ नहीं है कि होम्योपैथी के पिल के साथ ये दवा लिया तो क्या होता है, आयुर्वेदिक का भस्म के साथ ये लिया तो क्या होता है. लॉट ऑफ भस्म दे हैव स्टेरॉइड that will reduce your CD4 count. We have found people who have been taking something, सब अच्छा है, CD4 count नीचे जा रहा है, क्या हो रहा है, तो बोले मैं वो भस्म खा रहा हूँ, मत खाओ. तो साइड इफेक्ट का एक बहुत एक साइट भी है, लिवरपूल एडवर्स इफेक्ट .com कुछ है, उसके ऊपर आप मेडिसिन ये और दूसरा मेडिसिन डाल के देख सकते हैं क्या आता है.
Stanford of. Yeah. So the next question is, what is the role of nutrition and how nutritional supplements can help in HIV?
See, role of nutrition was earlier when ART was not available. It was very unaffordable. It was in the rudimentary stage. At that time, we had 4 stages of care: supportive care, symptomatic treatment, treatment of opportunistic infection, ART. तो ART सबसे नीचे था. अभी पूरा उल्टा हो गया, ART सबसे ऊपर आ गया, बाकी सब नीचे चले. तो न्यूट्रिशन का बहुत ज्यादा ये नहीं है, लेकिन अभी पहले माल न्यूट्रिशन में क्या था, पहले अंडर न्यूट्रिशन था, अभी ओवर न्यूट्रिशन. ओवर न्यूट्रिशन में आपको बैलेंस कैसा करना है, वो बैलेंस डाइट लेना है. तो आपको वो डिसाइड करना है कि गेहूं के जगह ज्वारी बाजरी नाचनी खा सकते हैं क्या, चावल कम कर सकते हैं क्या, पोटैटो कम कर सकते हैं क्या. बहुत लोग बोले नहीं मैं शराब नहीं पीता हूँ, मैं बियर पीता हूँ. मैं पूछता हूँ बियर में क्या गंगा जल है, यमुना जल है, क्या है. बियर में भी शराब ही है. बियर में ग्लिसरीन आता है, ग्लिसरीन से आपका वेट बढ़ता है. तो अगर आप बियर को पानी में उल्टा करो तो लगभग 45% ग्लिसरीन निकल जाता है. तो लोगों को न्यूट्रिशन में, खान पान में क्या बदलाव लाना है, वो इरिस्पेक्टिव ऑफ HIV है. HIV की वजह से आपको कुछ भी नहीं करना है.
Yes, sir. So in line with the same question, we have another question from Vishal. सर डाइट क्या लेनी चाहिए और इम्यूनिटी को बढ़ाने के लिए क्या होम्योपैथी ले सकते हैं?
देखो, इम्यूनिटी बढ़ाने का मतलब ये है कि आपको आप समझ रहे कि आपकी इम्यूनिटी कम है, आप इसलिए समझ रहे कि आपको HIV। तो HIV आपका इम्यूनिटी को कुछ नहीं कर रहा है, एक लेवल पे कम था, अभी दवा ले लिया, आपका इम्यूनिटी नॉर्मल हो गया। दूसरी चीज आप एक याद रखो, भगवान ने कई चीजें आपको डबल डबल दी है, दो आंखें दी है, दो नाक को होल दिए हैं, दो कान दिए हैं, दो किडनी दी है, मेल में दो टेस्टिकल है, फीमेल में दो ओवरी है, लेकिन जबान एक है और सेक्स ऑर्गन एक है। अगर दो थे तो आप इधर उधर करते थे। उसी ढंग से आपको इम्यूनिटी भी डबल है। और इसीलिए कि HIV होने के बाद भी 5 साल 7 साल कुछ नहीं होता था इवन नेचुरल कोर्स में विदाउट ART। क्यों? कि आपके पास 100% एक्स्ट्रा इम्यूनिटी है। इसका सिंपल एग्जांपल क्या है कि आपके एक सोलो बिल्डिंग है, बिल्डिंग में 4 वॉचमैन है, 4 वॉचमैन में से एक छुट्टी पे तो ड्यूटी कर रहे, वो एक वापस आया ही नहीं, तो 3 में एक जरा छुट्टी पे, 2 जने 12 घंटा ड्यूटी कर रहे, और 2 जने बोले नहीं हम लोग अफोर्ड नहीं कर सकते, 2 वॉचमैन की रखा है, तो 2 वॉचमैन में 12 12 घंटे की ड्यूटी करेगा, कभी सोएगा कभी चोर आएगा पता नहीं। लेकिन जब तीसरा भी नहीं रहेगा, 24 घंटा एक जना ड्यूटी नहीं कर सकेगा, तो जब आपकी इम्यूनिटी 25% पे आती है तब आपको प्रॉब्लम होते जाए। 100% तो एक्स्ट्रा है, तो जब 200 में से 100 होगा तब कुछ नहीं होगा, 100 में से 50 जाएगा तो प्रॉब्लम चालू होगा। इसका मतलब 3/4 इम्यूनिटी कम करने में तो बहुत टाइम लगता है। और आपको तो जब ART चालू कर दिया, इम्यूनिटी नॉर्मल पे आ गई, कभी कभी आपकी इम्यूनिटी अगर आपको देखना ही है थोड़ा टेस्ट करके, आपको और जो HIV नेगेटिव उसका जाके CD4 कर लो, कभी हो सकता है उसका दूसरे का CD4 कम है, आपका CD4 ज्यादा है। तो इम्यूनिटी आपको बढ़ाने के लिए कुछ नहीं करना है, क्योंकि आपकी इम्यूनिटी अपनी अच्छी है। तो ये आपको डे टू डे रेगुलर हैबिट, एक्सरसाइज, योगा, मीटिंग पीपल, गोइंग आउट, वॉकिंग, वो वो एक डायबिटीज के कॉन्फ्रेंस में दिखाया कि डायबिटोलॉजी सबको बोलते हैं आप इतना वॉक करो, ये करो, वो करो, और वो कॉन्फ्रेंस में वो एस्केलेटर से, सब डायबिटोलॉजिस्ट एस्केलेटर से आ रहे हैं, 2 लोग बेचारे सीढ़ी से आ रहे हैं, तो वो खुद तो चलते ही नहीं, तो दूसरों को बोल रहे हैं आप चलो। तो ये भी होता है कभी कभी।
Yes, sir. So we have last two questions for this session. That is, what kind of sexual health related education be given to older and younger women with childbearing age?
देखो हम लोग पहले क्या था, आई थिंक प्रॉब्ली रैपो, एक्सपीरियंस, ऑल दिस थिंग मैटर्स। तो हम लोग पहले पेशेंट लोगों से सेक्स की ज़्यादा बात नहीं करते थे, तो अभी हम कैजुअली पूछ लेते हैं। और उसमें पूछने में क्या हो रहा है कि कई बार जो हमारे दिमाग में पहले रहता था कि ये वीडियो है, HIV पॉजिटिव सेक्स नहीं करती होगी, ऐसा नहीं है, वो भी करती है। ये वीडियो और है, वो सेक्स नहीं करता, वो भी करता है। तो आप पूछते हैं, हो सकता है पहली बार में नहीं बताए, सेकंड टाइम बताए, तो हम लोग उनको नॉर्मलाइजेशन ऑफ ऑल लाइफ, सेक्सुअल लाइफ, मेंटल लाइफ, फिजिकल लाइफ, पर्सनल लाइफ, सब नॉर्मलाइजेशन। हम बोलते हैं कि आपको अगर HIV नहीं होता तो आप क्या क्या करते, सब करो। HIV होने की वजह से आप कुछ मत स्टॉप करो, आप बिजनेस बढ़ाते बढ़ाओ, आप फॉरेन ट्रैवल कर सकते करो, एक्सेप्ट दैट यू कैनॉट गो एंड वर्क इन सम गल्फ कंट्रीज बिकॉज दे आर फुलिश। आई डोंट नो व्हाई दे कंटिन्यू टू हैव दैट काइंड ऑफ स्ट्रिंजेंट गाइडलाइन। अनडिटेक्टेबल को भी वो नहीं लिख लेते। बाकी आपको कुछ भी नहीं करना है। तो HIV है तो क्या हो गया, कुछ भी नहीं होता है, आप सब करो। तो बी नॉर्मलाइज, एंड देयरफॉर वो सेक्सुअल हेल्थ का जो इम्पोर्टेंस है, वो एक जगह सेक्स एजुकेशन देना चाहिए, गवर्नमेंट में क्या करना चाहिए, बचपन में क्या होना चाहिए, वो अलग बात है। लेकिन our parameter is very simple. We are dealing with our patient lives, and we are asking them to normalize everything. If at all you are taking risk of not, you will infect the partner with HIV. The risk is to will be getting other infections. Therefore, use condom. Otherwise, nothing is required, because we are getting a lot of people with HIV coming with gonorrhea, chlamydia, syphilis, and I hardly find out of 100 doctors, 1 or 2 are willing to give penicillin injection. We are giving in our clinic because patient जाते बेचारे घूमते रहते थे, पेनिसिलिन का इंजेक्शन नहीं मिलता, 20 rupees costing. I salute Pfizer for that. That Pfizer is the company, and another company is there in India which makes penicillin, but that is 3 times more expensive. Nobody makes penicillin, and nothing works except long-acting penicillin in syphilis. तो पेनिसिलिन मिलता नहीं है, इंजेक्शन देने वाला कोई नहीं है, तो बड़े प्रॉब्लम है सेक्सुअल हेल्थ में। इसलिए प्रोटेक्शन का इस्तेमाल करो, लेकिन नॉट बिकॉज यू विल इन्फेक्ट समबडी विद HIV.
Yes. So the last question for the session is, what message would you like to send to your younger people living with HIV or people with one newly? In this, sir, I could relate your proverb. that is undetectable is equal to untransmittable, and which eventually leads to life is fully predictable.
So the young people who got HIV, okay, the reason they got is because I called it a cohort effect. Cohort effect was such that we had a very high profile campaign for HIV prevention till almost 2010. And those who are now 20, 22, 25 and got HIV, they were very young at that time, 5 or 6 years of age that time. They were not exposed to that high profile campaign. And in last 10, 15 years, that HIV prevention campaign, high profile campaign, HIV march, HIV exhibition, they're all almost non-existent. We talk about HIV only on World AIDS Day. Thereafter, there before, after, nothing is talked. And therefore, they got HIV unfortunately because they were never exposed to that kind of awareness. Secondly, initial thing was that HIV is transmitted through sex workers. Now, hardly anybody gets from sex workers. They are all going to massage parlors. Thirdly, they have been not guided at that time. They picked up HIV. But anyway, you got HIV, you be regular, take treatment, become undetectable as early as possible. Within 2 to 3 months, you become undetectable. Earliest undetectable I have seen was in maybe around 45, 50 days or something. So, and once you become undetectable, it's as good as normal life. So initially parents were talking about सब उसकी शादी करना है कहीं करना है तो उसको ढूंढने दो आपके कोई दिमाग में लड़की है तो लेके आओ. There are a lot of people, they have some hookups, bring, we counsel them, they say no, we will go ahead with marriage. Earlier, I used to always say, दो लोग बदनाम है, एक डॉक्टर गिलाडा और एक मुन्नी, को कोई शादी को नहीं बुलाता था, हमको कोई सेलिब्रेशन नहीं बुलाता, बोले इसको बुलाया तो पता लगेगा इसको HIV है, आजकल शादी को बुलाते हैं, इसको बुलाते हैं, तो इतना नॉर्मलाइजेशन काफी हो गया है. तो यंग लोगों में you don't worry at all, you live a full life with your wife, she getting no infection, child getting no infection, produced children, no problem. वो हिंदुस्तान की आबादी को मत देखो, अपनी खुद की घर की आबादी देखो, 1-2 बच्चे 3 बच्चे चाहिए, कोई बड़ा प्रॉब्लम है. तो HIV is no more a deadly and killer disease. You can predict your life, you continue your business, continue your profession, continue your education. Nothing should stop you just because of HIV status.
Yes, sir. Thank you, sir, for addressing all the queries which are raised by our doctors as well as the participants who have attended this event. We are really grateful to have a session with you on the upcoming the HIV Long-Term Survivors Day. Thank you again, and thank you for all the participants for joining the session.
Thank you, sir.